Welcome everyone to today's webinar titled Antimicrobial Stewardship and Immunocompromised Host, to be presented by Dr. Deresinski and Dr. Marisa Holubar from Stanford University School of Medicine. We're excited to have both of our presenters today. This is Dr. Marty Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, launched last year by the Center for Infectious Disease Research and Policy at the University of Minnesota. These webinars are part of our project, and we have some very esteemed experts today. Dr. Stan Deresinski is also an advisory faculty member to our project. He's a clinical professor of medicine at Stanford, where he is the medical director of the Stanford Antimicrobial Safety and Sustainability Program and chair of the Pharmacy and Therapeutics Committee. He's currently editor of Infectious Disease Alert and for more than a decade has been section editor of Clinical Infectious Diseases. Dr. Deresinski is a current member of the Antimicrobial Stewardship Committee of the Society for Healthcare Epidemiology of America. He is also a recent past chair of the Standards and Practice of the Infectious Diseases Society of America, IDSA, as well as a member of its board of directors. Dr. Holubar is a clinical assistant professor of medicine at Stanford, where she is the Associate Medical Director for the Stanford Antimicrobial Safety and Sustainability Program and the Infection Prevention Program. Together with Dr. Deresinski, she is the course director of 3 online courses on antimicrobial stewardship and is also collaborating with the World Health Organization to educate frontline clinicians worldwide on the optimal use of antibiotics. She's a member of many societies and serves on their committees such as IDSA Education Committee and the IDSA Staphylococcus aureus Bacteremia Guidelines Writing Panel, as well as the California Department of Public Health Healthcare Associated Infections Advisory Committee. So there are 2 esteemed experts that will be speaking to us today on a topic that they published on actually this year. For participants, I just want to remind you that at any time during the webinar, you're encouraged to engage with us, engage with our experts by submitting questions and comments in writing in the chat box on the lower right-hand corner of your screen, which you can see there. Go ahead and type in your questions, comments, and please submit them to all panelists, and we will have time to address them at the end of the webinar. And then finally, all of the lines will be muted during the webinar. However, this webinar will also be recorded and available at a later day via our Antimicrobial Stewardship Project YouTube channel. So with that, I'd like to thank all of our participants for joining us and welcome our presenters. Dr. Deresinski.
Thank you. Let me just mention that one thing about the introduction, which was very nice, is that I'm not actually editor of clinical infectious disease, just a section editor, and I wouldn't want my colleagues to be upset. So,
thank you for that clarification.
Okay. So I'll be handing this off to Marisa and then coming back again at the end. But I think that we're hearing more and more quotes from public officials, but I still think that the one by Professor Dame Sally Davies from 2013, who is the Chief Medical Officer for the Department of Health in London, is still very powerful. She talks about modern surgery. If in the circumstance that we have increasing numbers of untreatable infections because of antibiotic resistance, that modern surgery would be unacceptably dangerous. And then furthermore, and more to the point directly, which we'll be talking about today, is that cancer chemotherapy and organ transplantation would no longer be viable. We wouldn't be able to do these if resistance progresses to the point that it becomes highly prevalent. So now is the time for action. Most of us can't do anything about the use of antibiotics in animal feed and the like, but we can have an effect within our institutions on appropriate use of antimicrobials. Okay, I'll figure out this keyboard in a moment, sorry. When we talk about immunocompromised hosts, there's really a great variety, and this just lists some of the acquired causes of immunocompromise, such as solid organ transplantations, hematopoietic stem cell transplantations, and chemotherapy, which we'll be focusing on today. And we'll also be talking about the use of one group of immunomodulatory drugs, which are used for the treatment of cancer, the checkpoint inhibitors, which will come up, as you will see, in our discussion of the microbiome, which we'll spend some time on because it really is, in large part, the basis for much of the problems that occur as a result of antibiotic use as well as other activities, and really form the basis of the science behind this. We also know that the number of patients at risk are increasing dramatically. On your left, you see the increase in numbers of both autologous and allogeneic transplantations in the United States through 2015 with a progressive increase. You might question what happened at the end of the 1990s in terms of the dramatic drop in autologous transplants, and that was related to the fact that prior to that time, many women with breast cancer were receiving autologous transplants until it was discovered that they were not at all beneficial. So the numbers decreased dramatically at that point, but as you see, the total number of transplants has increased since. In terms of, on the right, of solid organ transplants, you can see that in the U.S. in 2016, there were almost 34,000 solid organ transplants performed, led by kidneys, followed by liver and lung, heart and lung transplants. Now, implementing antimicrobial stewardship in many institutions, general hospitals, is problematical, and if it's problematical there, it may be especially problematical in many in dealing with these immunocompromised patients for a whole variety of reasons, only some of which we've listed here. There's really often great diagnostic uncertainty, in part because of the complicated clinical picture and all of the other causes of things that look like infections but aren't in these patients, such as organ rejection, graft versus host disease, and the like. At the same time, there's really a lack of high-level evidence. The number of randomized trials dealing with infections in these patients approaches the non-existent. And then finally, in many institutions, you will face prescriber opposition. You'll hear responses such as, "That's the way we've always done it. My patients are sicker than everybody else's." But what's underlying all those is really a psychological issue that we see everywhere in the prescription of antibiotics, including the outpatient setting, and that's clinician fear. Despite the barriers, a recent survey sent out by Susan Seo at Memorial Sloan Kettering indicated that many institutions do have stewardship programs and that they're applying them to immunocompromised patients. 62 of the 71 centers had an institutional stewardship overall. Of the 62 centers, perhaps two-thirds reported that they included immunocompromised host patients. And you can see on your right the kinds of activities that were included, and they will look very familiar to you because they are the same ones that we do in general hospital populations. And in fact, the principles of stewardship really are no different in the immunocompromised patient compared to the non-immunocompromised patient. However, despite these survey results, which look pretty good, although not great. The fact of the matter is it's likely that the implementation of many of those activities and the adherence to them is probably less than indicated. Now, this is a circumstance recounted here in which there was fairly good adherence. In this circumstance, of 103 patients who received antibiotics, and these are solid organ transplant patients, approximately 70% of them, the antibiotic therapy was concordant with stewardship principles. However, a major reason for this, I'm sure, was because they have an infectious disease consultation service devoted to transplant patients, the Transplant Infectious Disease Service. And whether or not there was adherence with stewardship principles depended significantly on whether there was such a consultation. So the Infectious Disease Service was involved in 54% of the episodes, and their involvement was more likely to lead to antimicrobial stewardship adherence than those without their involvement. So, and this was statistically significant, 78.5% versus 59.6%, with a calculated p-value of 0.03. And if go deeper into it, it turns out that in those patients for whom an infectious disease consultation was obtained, the reason for discordance in 2/3 of the episodes was because the transplant team didn't do what the infectious disease team recommended, a phenomenon with which we probably are all quite familiar. The most frequent categories of discordance are seen below, and they're not really, again, any different from what we see in the general population, and that is the empiric therapy was too broad, there was a lack of de-escalation, and the duration of therapy was too prolonged. So, as we go on here, we're going to talk first about the harm associated with antibiotics, and then some examples of application of stewardship principles in the immunocompromised population. We're all aware of the effect of antibiotics on selection of resistance in the gastrointestinal microbiome, but it turns out that's not the whole story. There is a great deal of accumulating evidence that alterations in the gastrointestinal microbiome, many of them, probably most often caused, or to a greatest extent caused by antibiotics, although there are multiple reasons for the microbiome to be altered in many of these patients, that there are other adverse effects from alteration of the microbiome that go beyond the selection of resistant organisms. At the third bullet point here, there is published data that indicates that the occurrence of so-called domination events by pathogens in the microbiome is associated with subsequent infection. An excellent example of that actually is VRE in hematopoietic stem cell transplantations. There's good evidence that shows that just having gastrointestinal colonization doesn't predict subsequent infection by VRE. What is predictive is when the VRE becomes a predominant organism within potential pathogens within the gastrointestinal tract. And you see to your left what happens to the frequency of so-called domination events over weeks of chemotherapy and neutropenia. In the study here, all of 34 adults, all of whom are receiving antibiotics, some prophylactic, some therapeutic, some both. The loss of diversity, so as you restrict the genera within the gastrointestinal microbiome, that loss of diversity is associated with an increased risk of infection not just during the period of neutropenia, but in the 90 days after neutrophil recovery. So it has a lasting effect. This study looked at early versus late administration of antibiotic in patients receiving conditioning therapy and then transplanted with hematopoietic stem cells. The risk of transplant-related mortality was the lowest in those relatively few patients, 88 patients, only 6 of whom had a fatal event if they had no systemic antibiotics during that period, or 7%. Individuals who received antibiotics in the 7 days prior to the actual transplantation, so this is the period of neutropenia from the conditioning program, the mortality rate, transplant-related mortality rate, was 34%, and it was only 21% in those who received it later. So there's a profound effect of antibiotics, and the earlier they're given in this particular setting, the greater the transplant-related mortality. And the effects are multiple. Besides the reduction of microbiome diversity, there's the occurrence of dysbiosis, which predominantly relates to alteration in metabolites that are produced, such as butyric acid, and result in changes in gastrointestinal mucosal immunity, the risk of infection, as we just saw, and the occurrence of graft versus host disease. From the study we just discussed, the type of antibiotic has an effect on eventual transplant-related mortality. So that administration of antibiotics that are active against commensal organisms, especially Clostridiales, which are among the organisms that are butyrate producers, is associated with poor outcomes. As we saw, the loss of microbiome diversity is associated with a risk of invasive infection, as well as a risk, it turns out, of the occurrence of graft versus host disease. And in particular, in one study, the administration of imipenem or piperacillin tazobactam was associated with graft versus host disease-related mortality. And then finally, there's another study that found that the composition of the gastrointestinal microbiome is associated with increased risk of relapse of malignancy in transplanted patients. This study looks at the relationship between antibiotic exposure and response to chemotherapy, in this case in patients with chronic lymphocytic leukemia who were given cyclophosphamide. 45, and they were particularly interested in gram-positive antibiotics. Antibiotics of predominant anti-gram-positive activity because of some mouse studies that had been published. And what they found was that the administration of such an antibiotic, which would be active against the Clostridiales, for instance, was in fact an independent risk factor for reduced progression-free and overall survival, as you see in the Kaplan-Meier plots on your right. So that's chemotherapy. So there's at least one study that suggests that antibiotic administration may impair the response to chemotherapy in one particular disease, at least. But very recently, there's been some very interesting data published on the response to checkpoint inhibitors. So in this study, just published in Science last week, 249 patients were treated with monoclonal antibodies to either programmed cell death 1 or PDL1 ligand, 140 with non-small cell lung cancer, 67 with renal cell carcinoma, and 42 with uroepithelial carcinomas. 28% of these patients received an antibiotic in a period of 2 months before to 1 month after the administration of their checkpoint inhibitor. And what the investigators found was that antibiotic exposure during that period of time and associated microbiome changes were in turn associated with reduced survival, both progression-free survival and overall survival. And you see that information to your left for all cancers and then for each individual cancer. A very profound effect. Also in that same issue of Science was this publication. So basically they related the response to anti-PD-1 immunotherapy in melanoma patients, so a different group of malignancies, to a so-called favorable and unfavorable microbiome. The favorable microbiome was again associated with butyrate producers, the Clostridiales and others. It was associated with maintenance of high diversity within the microbiome, and there was evidence that this was associated with an enhanced anti-tumor environment, both locally and systemically. And the unfavorable environment was with low diversity and abundance of Bacteroideales. And you see on the left the progression-free survival related to the diversity of the gastrointestinal microbiome. Those with high microbiome diversity clearly had superior progression-free survival relative to those with low or even intermediate levels of microbiome diversity. And again, antibiotics significantly reduce the diversity of the gastrointestinal microbiome. So just to summarize what is a lot of data, let me just go through these next 2 slides. First of all, although multiple factors may affect the gastrointestinal microbiome, antibiotics clearly have a potent effect, including the loss of bacterial diversity. In neutropenic patients, there's evidence that the domination events, the predominance of individual pathogens, is associated with an increased risk of infection. That clearly makes some sense. Loss of diversity is associated with increased infection risk for 90 days after recovery from neutropenia, indicating a persistent effect. In allogeneic hematopoietic stem cell recipients, early antibiotic administration is associated with increased mortality. Antibiotic exposure, especially with imipenem or piperacillin tazobactam in one study, was associated with an increased risk of graft versus host disease. The microbiome composition is associated with an increased risk of malignancy relapse. Antibiotic exposure is also overall, in other circumstances, associated with a reduced response of chemotherapy and CLL and a reduced response of checkpoint inhibitors, and this is attributed to microbiome changes, including reduced bacterial diversity and loss of butyrate-producing bacteria. I think that this sort of data could provide potent arguments to our transplant colleagues with regard to antimicrobial stewardship implementation. And now we're going to talk about some examples, and Marisa will take over.
Okay. Thank you, Stan. So we thought it would be illustrative to focus first on fever and neutropenia. So as you all are aware, fever and neutropenia is common. Most standard dose chemotherapy regimens are associated with 6 to 8 days of neutropenia. Sorry for some of that background noise. And fever and neutropenia is observed in about 8 of 1,000 patients receiving chemotherapy. Neutropenia is even more common in patients with AML or myeloablative conditioning prior to stem cell transplant due to the prevalence of neutropenia associated with these conditions. And this is not a benign syndrome. 20 to 30% of patients that present with complications of fever and neutropenia that require in-hospital management, and this alone carries about a 10% inpatient mortality risk. And historically, bacteremia or documented infections is only detected in a minority of patients, so this is a difficult population to manage. Current guidelines recommend antibiotic prophylaxis for patients at greatest risk of developing fever and neutropenia, most commonly through the use of fluoroquinolones. However, fluoroquinolone prophylaxis does not appear to prevent all cases of fever and neutropenia, as many of you would attest to in your clinical practice. In this study, which was presented at ID Week this year, the authors reported their institution's experience before and after instituting fluoroquinolone prophylaxis for patients undergoing autologous stem cell transplant. They found that in the era when prophylaxis was not used, 89% of patients developed fever and neutropenia. However, after prophylaxis with levofloxacin was instituted, only 59% of patients developed fever and neutropenia. So although there was a reduction, this clinical syndrome was clearly not eliminated. So in the next few slides, we'll review the management of fever and neutropenia using an illustrative case in which the management, as you'll see, is often discordant with available guidelines. And thus will demonstrate opportunities for programs to intervene in the management of these patients. So our illustrative case is a 42-year-old man who presents with fever and neutropenia during the consolidation therapy for AML. He has no localizing symptoms. Prior to the diagnosis of AML, he was healthy. His temperature on presentation is 38.8 degrees Celsius. His heart rate is normal, as is his blood pressure, and his physical examination is normal except for minimal mucositis, some suggestion of dehydration, and an implantable central venous access device that does not have any overt evidence of infection. His ANC is 120, his platelet count is 22,000, his chest X-ray is normal, and his serum lactate is 0.6. The managing team administered IV fluids for the suggestion of dehydration, although the patient had normal blood pressure. Blood cultures were drawn, and cefepime and vancomycin were started, and he was admitted to the hospital. So through the discussion of this case, we will address some of these stewardship-related issues, namely, do these patients, and our patient in particular, require hospital administration? This is pertinent to stewardship programs that are involved in outpatient antimicrobial therapy programs. If a patient is managed as an outpatient, should his antibiotics be given IV or PO? Should vancomycin be part of the Empiric regimen for febrile neutropenia? And if vancomycin is administered and no organisms required its use are detected, can it be discontinued, and when? Another question is when empiric antibiotics should be changed in the setting of persistent febrile neutropenia, and of course, what is the necessary duration of therapy of these empiric broad-spectrum antibiotics? So let's tackle the first two questions first. Does this patient require hospital administration, and should his antibiotics be administered IV or PO? So in general, this patient does meet most criteria for febrile neutropenia, in that he is febrile and has an ANC very close to 100, which is the typical cutoff for guidelines for defining febrile neutropenia. And he is likely to have a prolonged reduction in ANC given his underlying conditions and his conditioning regimen. So the recommendations from the IDSA and NCCN, or the National Comprehensive Cancer Network guidelines, do provide recommendations of how to stratify patients and make these early decisions. The risk assessment then helps people determine the type of empirical therapy, the venue of treatment, and the duration of antibiotic therapy. So the IDSA guidelines considers high-risk patients to be those with anticipated prolonged or greater than 7 days duration of profound neutropenia of an ANC less than 100, and or significant medical comorbid conditions that include hypotension on presentation, pneumonia, new onset abdominal pain, or neurologic changes. Guidelines and recommend that these patients that are considered high risk be admitted to the hospital for empiric IV therapy because they are at higher risk of complications for febrile neutropenia. Low-risk patients are those that obviously do not meet the criteria for high risk and are considered candidates for outpatient therapy, perhaps with an early IV dose followed by oral doses of antibiotics. The guidelines also suggest that in addition to using these kind of broad clinical parameters, that clinicians can use a formal risk classification to help determine who is high and low risk. The Multinational Association for Supportive Care in Cancer, or the MASC Risk Index, is shown here, and this is a validated tool for measuring the risk of neutropenic fever-related complications in adults. The components of this algorithm include mostly objective data, and a higher score indicates lower risk with a maximum of 26 points. The disclaimer for this particular validated risk score is that some of the comorbid conditions listed in the IDSA guidelines are not included in this algorithm, so clinical judgment may override the actual score. In our patient's case, he had really no or mild symptoms. He had no evidence of hypertension. He did not have a history of COPD. He had a hematologic infection, and we had no indication that he had a prior fungal infection. He was somewhat dehydrated, and he was febrile in the outpatient setting and young. So he really had only one element, and thus his MAS score was greater than 21, which is considered low risk in the guidelines. There has been some suggestion that other validated scoring systems, specifically this one, the Clinical Index of Stable Febrile Neutropenia, may be more reliable. This scoring system was developed to predict major complications in outpatients with solid tumors receiving mild or moderate intensive chemotherapy and were clinically stable. So there's discussion in the literature about that. So despite criteria and validated scoring measures to help clinicians classify their patients as high or low risk, many institutions experience a bias towards admitting patients with febrile neutropenia regardless of risk to their hospital. And this group demonstrated that by performing a retrospective chart review of all patients with fever, an ANC less than 1,000, and no localizing signs or symptoms of infection. They included 173 patients, and they found that, so the majority of these patients had either a solid organ tumor or a hematologic malignancy. Very few were stem cell transplantations. And the authors ended up classifying 25% of these patients as low risk by IDSA criteria, and the rest as high. And they found that management was guideline discordant in 98% of the patients with low risk, classified as low risk, compared to 7% in the patients that were classified as high risk, and noted that the biggest issues were related to setting of care and appropriate or inappropriate antibiotic route. So many of these patients could have been considered candidates for outpatient management, but were admitted to the hospital instead. So back to our patient. Remember, this patient was empirically started on cefepime and vancomycin, and the question is, was this appropriate? The IDSA guidelines are very clear that vancomycin is not recommended as a standard part of empiric antibiotic therapy for febrile neutropenia. They cite randomized controlled trials that showed no significant reductions in either duration of fever or overall mortality in the arms that included vancomycin in their empiric regimen, and certainly discuss the risk of overuse of vancomycin in encouraging the emergence of drug resistance. The IDSA guidelines put forth this table of specific indications for which vancomycin or other antibiotics that are active against resistant gram-positive organisms are indicated, and these include hemodynamic instability or the signs of severe sepsis, essentially when the margin for error is small, or in patients that have evidence of skin and soft tissue infections that may require coverage for resistant gram-positive organisms. It's important to note that the presence of a central venous catheter without evidence of overt infection at the site is not enough to warrant empiric vancomycin. So according to this criteria, our patient did not meet criteria for starting vancomycin empirically. However, as many of you are already aware, empiric vancomycin for patients with febrile neutropenia does vary by institution. So these first 2 points are related to the study that I just reviewed that showed that 25% of patients with febrile neutropenia were low risk but aggressively managed. But this group found that only a minority of the time that vancomycin was used was it discordant with guidelines. So despite overall aggressive management, vancomycin was not misused often in their retrospective review. This is in contrast to other reports, such as the one listed here in the third bullet point, that was another retrospective review of adult cancer patients with febrile neutropenia, and only 38% of them had guideline concordant use of empiric vancomycin. So the rate of inappropriate vancomycin use varies significantly. One reason vancomycin is used widely is reports or self-reported penicillin allergies in patients that require antibiotics. This is not unique to immunocompromised hosts, but because these patients need antibiotics more frequently and for prolonged periods of time, a false penicillin allergy can significantly impact their clinical course. So in this study, as one of several that have been presented, that looked retrospectively at Cleveland Clinic's experience, and they implemented a protocol to routinely test patients with reported beta-lactam allergies prior to undergoing stem cell transplant. And they found after implementation of this protocol that penicillin skin testing, the prevalence of penicillin skin testing increased significantly. And with that penicillin skin testing and thus delabeling, the average GOT use of antibiotics decreased, and specifically that was noted for vancomycin with associated decreased pharmacy spend on that drug. Okay. Let's return to our case again and imagine it's day 3 of his hospitalization. He is still febrile, still neutropenic, and still clinically stable. Despite this, and the fact that his admission blood cultures are negative, the team taking care of him changes his empiric cefepime to meropenem and decides to continue vancomycin. So the question is, was this appropriate? So as mentioned previously, IDSA guidelines are specific in terms of listing indications for the appropriate empiric use of vancomycin, but they're also very clear about when vancomycin, if it is started, should be discontinued. This is a direct quote from those guidelines that say if vancomycin or other coverage for gram-positive organisms was started initially, it may be stopped after 2 days if there is no evidence for a gram-positive infection, that being on physical exam and in the setting of negative blood cultures, like is the case for our patient. However, as is probably the experience of many people listening to this webinar, that empiric vancomycin is both inappropriately started and inappropriately continued often. So in the retrospective review I previously discussed of the 128 adult cancer patients with febrile neutropenia, only 27% of them had guideline concordant duration of empiric vancomycin use. So because of this problem with inappropriate starting and inappropriate lack of discontinuation of vancomycin, it begs the question if this problem is amenable to clinical pathways implementation. And this study supports that idea. So this was a retrospective analysis of vancomycin use pre and post the introduction of the clinical pathway. That was introduced in a patient population that was primarily for adults that had solid tumors or hematologic malignancy in the majority of these patients. And they found with the implementation of the pathway that both initiation and duration of vancomycin use was more concordant with guidelines. And should be noted that this institution didn't have a very high, or at least grossly high, proportion of discordant use to begin with, but yet they still saw an improvement. And then, in patients with persistent fever and neutropenia, when should the empiric broad-spectrum antibiotics be altered? Guidelines recommend that in patients with unexplained persistent fever, in those who are otherwise clinically stable, rarely require an empiric change in this gram-negative coverage. So in this patient's case, he did not require a change in his empiric gram-negative coverage, nor a continuation of his vancomycin. Now let's imagine it's 96 hours into his course. He again remains clinically stable, remains febrile and neutropenic, but at this point he's undergone a high-resolution chest CT that was normal and had a serum galactomannan that was negative, as well as a sputum culture that did not show any evidence of a fungal pathogen. Despite this, his team continues meropenem, continues vancomycin, and adds an anti-mold agent of voriconazole. So guidelines suggest that patients that have had prolonged fever, in this case greater than 4 days, should be considered for empiric anti-mold therapy, and they provide two options, either just empiric antifungal anti-mold coverage, or what's considered a preemptive approach, using diagnostic tests to determine if antifungal therapy should be used. And this is what they specifically say about this preemptive antifungal management, otherwise known as diagnostic-driven antifungal therapy. They say that it's acceptable as an alternative to empiric antifungal therapy in a subset of patients who remain febrile but are clinically stable, have no clinical or chest or sinus CT signs of fungal infection, have negative serologic assays, results for an invasive fungal infection, and have no recovery of fungi from any body site. This hasn't, a full discussion, this is kind of beyond the scope of today's webinar. However, it's important to note that this diagnostic-driven antifungal therapy approach has been shown to be cost-effective compared with the standard empiric approach, likely because most of these patients who are empirically started on anti-mold agents are also undergo a diagnostic workup anyway. So now, on day 6 of this patient's course, he's still clinically stable, febrile, and neutropenic. At this point, the team is really concerned. They switch from meropenem to ceftolozane tazobactam and add tobramycin for extended gram-negative coverage. As previously discussed, this is probably not indicated, but it does bring up the question of, besides the fact that he shouldn't have had his empiric gram-negative therapy changed, could he have been de-escalated to fluoroquinolone prophylaxis given his stability? So the IDSA guidelines give clinicians two options. They say that the initial regimen, in this case it would have been cefepime, could be continued until there's evidence of marrow recovery. Traditionally that is seen as an ANC greater than 500. But alternatively, if an appropriate treatment course has been completed and all signs and symptoms of documented infection have resolved, including fever, patients who remain neutropenic may resume oral fluoroquinolone prophylaxis until recovery. As mentioned previously, there are multiple guidelines regarding the management of febrile neutropenia, and they all take a different stance on when patients could be considered for de-escalation back to fluoroquinolone prophylaxis. We've listed them here for comparison. These IDSA guidelines here are similar to what NCCN says. The remainder here are European guidelines. The ESMO guidelines recommend consideration of de-escalation when patients has been afebrile for 5 to 7 days. The EASL guidelines recommend discontinuing these broad-spectrum therapy if patients have been afebrile and hemodynamically stable for 2 to 3 days, irrespective of neutrophil count. And very recent German guidelines recommend a week of stable defervescence without clinical signs or symptoms of infection before de-escalation to fluoroquinolone prophylaxis. This has been looked at and described in 3 abstracts that were reported at a recent ECMID. This is one that was a retrospective study of adults who developed febrile neutropenia pre-engraftment, and they received broad-spectrum antibiotics for at least 5 days, and after they had been afebrile for 3 consecutive days, they were either randomized to discontinue broad-spectrum antibiotics and start prophy, or continue their broad-spectrum antibiotic regimen until their ANC count recovered. And they found no difference in fever recurrence and no difference in length of stay, ICU admission, or mortality, or need for re-escalation of antibiotics in these 2 populations. And as you would imagine, there was less broad-spectrum antibiotic use in cohort 1, in which the broad-spectrum antibiotics was discontinued early. 2 other groups had similar study designs with different timing in terms of de-escalation. These were patients in the first box or chart were randomized after 3 days of defervescence, the second group after 5 days of defervescence, and the take-home point is they saw no difference in the 2 groups that were de-escalated to fluoroquinolone prophy or those that were continued on broad-spectrum IV antibiotics. This is another study that is relevant to this discussion. These are children who had febrile neutropenia and presented with respiratory complaints, who had evidence of a respiratory viral infection on a microarray and negative sputum cultures and blood cultures for bacterial process. These patients were randomized at 48 hours if they had had a favorable evolution to either going back to prophylaxis or continuing their broad-spectrum IV antibiotics. And again, in this group, they found no difference in their primary outcome, which was uneventful resolution of the entire clinical syndrome. Briefly, we wanted to mention procalcitonin, as this is a very helpful tool for determining duration of therapy for patients with ventilator-associated pneumonia or sepsis of unclear origin in the ICU. And in this particular randomized controlled trial, procalcitonin was not helpful in limiting the duration of therapy for patients with febrile neutropenia. And part of that problem was lack of adherence to the procalcitonin protocol. But procalcitonin may not be as promising of a tool in this population as it is for others that the stewardship programs address. And finally, one other potential tool that is maybe helpful for stewardship programs and clinicians in general is that of next-generation sequencing, given that many of the patients with febrile neutropenia do not have positive blood cultures. This study here was performed by Dr. Deresinski and colleagues, and they found that in patients with febrile neutropenia, there were 5 patients that had both positive blood cultures and concordant next-generation sequencing results, but 18 patients that had organisms detected by next-generation sequencing but not by blood cultures. So some suggestion that finding the diagnosis for patients might be more promising with these new diagnostic measures. So finally, just to wrap this up, at day 28, this patient became stable, or remained stable as he had been the entire part of his course. He is now an afebrile and his ANC recovered with no evidence of AML relapse, and all of his antimicrobials were discontinued, and he was discharged home. So we're running short of time. I'm going to switch back over to Dr. Deresinski to wrap this up.
Okay, thank you. Just going to talk about 2 topics briefly that don't fit into what we've been discussing to this point. One of them is the use of aerosol ribavirin for community-acquired viral respiratory tract infections, which was widely used at our institution in lung transplant patients and in hematopoietic stem cell transplant patients. At the end of 2015, as part of our regular review of our transplant infectious disease team, one of our colleagues, Brian Blackburn, reviewed the literature looking at metapneumovirus and parainfluenza virus infections, and the conclusion from that was that there was no evidence of any benefit from the use of aerosol ribavirin. Subsequently, we also reviewed this with regard to respiratory syncytial virus infection, and found again that at least relative to oral ribavirin, there was no apparent difference in outcomes. But in fact, there was no absolutely convincing evidence that giving this drug by any route was effective. There was recent published data that subsequently that showed that in vitro ribavirin at serum concentrations that are similar to those seen in patients being treated for hepatitis C virus infection reduced macrophage macrophage viability by 20%, suggesting that in fact there may be a local adverse effect from aerosol ribavirin, which of course is delivered at very high concentrations into the lungs. And then finally, aerosol ribavirin is incredibly expensive, and the price you see at the right basically increased dramatically between 2011 and 2016, so that each day's therapy, and the usual therapy was approximately 5 days, just the drug acquisition cost alone was $24,000. We managed through extraordinary efforts to initially get the drug use stopped for parainfluenza and metapneumovirus infections, and you can see in the green line the overall dramatic decrease in aerosol ribavirin. We did not attempt to restrict the use of oral ribavirin, and its use increased accordingly. Oral ribavirin relative to the aerosol administration is extraordinarily expensive. Might also mention with regard to the expense that these patients were all hospitalized. Many of them would not have otherwise required hospitalization other than to get the aerosol ribavirin, and there are additional costs related to housekeeping, nursing, etc., in dealing with these patients. Then finally, in January of this year, we had allowed its continued use for respiratory syncytial virus infections. In January of this year, we took aerosol ribavirin totally off the formulary. We've had no adverse outcomes that we're aware of at this point, and the overall cost savings or cost avoidance is now in the millions of dollars. So this is a very effective target in circumstances that are using this product, as many still are. So let me move on to the final overall topic, and that is that we chose because there's really a lot of evidence. We're just showing you a little bit of this, and that is treatment of asymptomatic bacteria in renal transplantation. We're all aware that asymptomatic bacteria shouldn't be treated. There's been an argument that these infections may be associated with adverse outcomes and the like in renal transplant patients, but in fact, that does not appear to be the case. For instance, in this retrospective study, in which 59% of untreated bacteria is spontaneously cleared, there was no association between asymptomatic bacteria and organ rejection or the occurrence of chronic pyelonephritis. There was a small randomized trial looking at this effect, and rather than go through the algorithm in detail, they're basically, again, whether patients were treated or not, there was no difference in outcomes, including graft rejection. There are several other retrospective studies in addition to the one I showed a moment ago that come to the same conclusion. So I think it can be strongly argued that asymptomatic bacteria, at least after the first month or perhaps 2 months after transplantation, should not be treated. And there are things that we haven't discussed, other topics that we could get into. The widespread use of intravenous immune globulin for respiratory virus infections in transplant patients. The use of pelivizumab, Synagis, which is, of course, used for prevention of respiratory syncytial virus infection in at-risk infants. We, in fact, discovered that our lung transplant patients were using this in their patients with respiratory syncytial virus infection, and that use was stopped in July of 2015 with an estimated yearly cost avoidance of approximately $350,000 yearly. CIDRAP is another example. With regard to antifungals, when you use preemptive therapy, when do you discontinue it? The issue of IV to PO switch, particularly, for instance, in patients with candidemia. And, of course, the issues of rapid diagnostics, such as PCR testing, T2 for detecting candidemia, MALDI-TOF, etc. All of these are additional important concepts within the overall issue of antimicrobial stewardship in immunocompromised patients. So that's our summary, and actually this is our summary. Keep calm and do antimicrobial stewardship, not just in the general hospital population, but implement the stewardship principles in your immunocompromised patients as well. Thank you.
Thank you, Dr. Deresinski. Thank you, Dr. Holubar. That was very informative. Really opened your eyes up to it seems that there's a lot of opportunity within this patient population to practice stewardship. I just want to remind our participants, if you haven't already, please share any questions you may have or comments to Dr. Holubar or Dr. Deresinski at this time. We have a few minutes here for questions. I have just to start it off, clearly there's evidence that trying to avoid the use of antibiotics in either transplant patients or cancer oncology patients, if at all possible, is important because of its effect on the microbiome. I think that the paper that you presented, Dr. Deresinski, from recently published in Science Online is really an important paper. It makes me wonder as you collect more evidence in this field, if some of the guidelines may then change related to that.
There's no doubt that it will be difficult to restrict upfront use often, but clearly it's something that needs to be addressed. The other approach will of course be to try to alter the microbiome to a more favorable one by administration of fecal microbiota. But clearly, I think the interesting thing from all this is that antibiotics in these patients don't just select for resistance. They affect the overall outcome of therapies, both chemotherapy and immunotherapies, and affect overall survival as well as severe complications such as graft versus host disease. So we really need to work with our colleagues to rethink how we're managing these patients.
Absolutely. Dr. Holubar, nice presentation. I like the case related to the febrile neutropenia patient management. Do you see an instance where a low-risk patient that's febrile, negative on blood culture, is there a point of which, and it may be a wait and see where you don't use antibiotics? Or is there a place in time where as diagnostics advance, we're ruling out that there's a microbial infection that you're simply not going to use antibiotics and do more of a wait and see?
I think that certainly would be the ideal state if we had access to high yield and rapid turnaround diagnostics. There's certainly discussion in some groups of using point of care sequencing, unbiased sequencing, like the study that I included from Dr. Deresinski's group, but in a real-time fashion. I think in general, this clinical syndrome, even in low-risk patients, is associated with negative consequences that are pretty significant, and patients can get sick quickly. So without that access to quick turnaround and high-yield diagnostics, I think it will be difficult to withhold upfront antibiotics, and instead our focus, at least in current days, to perhaps consider some patients for early de-escalation back to prophylaxis.
Right. So there's a takeaway from a participant on listening today. That would be maybe one of the key places to focus first to try to have that impact.
Yes, and I think another, depending on participants' institutions, the appropriate empiric use of vancomycin and the appropriate discontinuation of vancomycin for high-risk patients admitted to the hospital is also something that is really amenable to stewardship implementation and, as we've shown, implementation of a clinical pathway.
A question that came from a participant related to the fecal transplantation. I don't know if you're seeing that, Dr. Deresinski. Is that something that you've seen? The question is around trying to speed access to that with current FDA restrictions.
Yeah, I don't think the restrictions are particularly onerous right now. I think that it's important to obtain consent from the patient, but this is not considered unless you're doing a research project on it. This can be just verbal consent and doesn't require an institutional review board. The use of commercially available product through, for instance, OpenBiome has made this a much simpler activity. You don't have to obtain your own product for administration. So I don't think that that's much of an issue. Let me mention one thing that maybe not directly related to this, but one of the interesting areas that's for which people are publishing currently and doing studies is the use of fecal microbiota transplant to eliminate gastrointestinal colonization with resistant bacteria, for instance, CRE or even VRE. The initial data that's been published is sort of mixed, but this is an area of very active investigation and will be of further interest.
Thank you for providing that additional information. We're actually out of time, unfortunately. I think this is such a fascinating topic, provided so much information here. I think it seems that it'll be continuing to evolve in this area, so maybe stay tuned and can come back another year from now and give us some highlights. So with that, I'm going to need to conclude the webinar, the Antimicrobial Stewardship Project webinar, which was recorded today and will be available on our ASP website. And thank Dr. Deresinski and Dr. Holubar for their thoughtful and very comprehensive webinar today. Thank you very much to all participants.
Thanks to everybody for listening.